Hi, everyone. My name is Eileen Anderson again. I'm director of the Stem Cell Research Center here at University of California, Irvine. I want to welcome you all and thanks for participating this evening or whenever you may participate in the future, at least virtually. I want to start out and say just a couple of words and then introduce our speakers. One thing that's really clear about an academic research university and special about it is that it's an aspect of how interconnected we all are. And that is really particularly true right now with the SARS-CoV-2 pandemic. While our job generally in Stem Cell Center is really about working to understand how stem cells work and how these can be harnessed to repair things like diseases of the eye, the brain, to help with wound healing and healing of things like the skin. Right now, current events really bring out a whole nother set of common goals that go beyond our roles in educating students and our everyday research. The UCI campus in that regard has come together in just tremendous ways to support the community in this area, developing new ventilator technologies, contact tracing apps, and in the case of the Stem Cell Research Center, we had the opportunity to step up and really help the medical enterprise by synthesizing some of the components that are necessary to do COVID-19 testing for our residents in Orange County. We're really proud to be able to do that and come together as a group here. With that, we have a tremendous number of members of the center who really bring unique expertise and some of which can be brought to bear in this pandemic as well. So I'm grateful to be able to bring together colleagues from within our center and a guest from the School of Medicine to address 4 topics tonight. These are an introduction to the virus underlying the pandemic, a discussion of COVID-19 testing, an open discussion on the ethics of opening up society during an ongoing pandemic, and some perspective as well on clinical trials for COVID-19 and how they relate to stem cell technologies. A couple of organizational things. I want to thank Dr. Goodwin, who's here this evening, for co-sponsoring this event from the Center of Biotechnology and Global Health Policy. I'm going to introduce each speaker individually. You can send questions. We invite the audience to send questions as we go. We will be collating these on the side, but saving them until the end. And at that point, I'll consolidate those and moderate to reach out to the individual speakers with the questions that have come in. But we will be doing those questions after the entire panel has finished. Please do understand if your specific question doesn't get asked, for some reason, if we run out of time or it's been consolidated with another, we will answer any of those that we don't get to online after the event this evening. And then just last, a couple of particular thank yous. Judy Beck from the Stem Cell Research Center here in charge of marketing has done just a tremendous amount of work in the background in order to make this event happen. And really a very special shout out to Dr. Brian Cummings, who is the chair of our community outreach committee here at the Sewinville Gross Stem Cell Research Center. And last, but not at all least, a shout out to UCI Media Services, and particularly Will Alvarez and Kyle Good, without whom we couldn't put on most of the events that we do at the center, and certainly we couldn't have survived this evening. So with that, I want to kick off by introducing Dr. Ming Tan. He received his bachelor's degree at the University of Florida, his MD at Johns Hopkins University. He's a professor here in the UCI School of Medicine in Microbiology and Molecular Genetics, and he is a specialist in infectious disease with a tremendous amount of expertise in this area. He will be presenting tonight on an introduction to SARS-CoV-2 and COVID-19. And so, Ming, I'd like to invite you to share your screen and take it away by kicking off your presentation. So thanks.
Thank you, Eileen. All right, so as Eileen said, I'm going to be introducing the virus SARS-CoV-2 that has dominated our lives and talk about the infection COVID-19. And so SARS-CoV-2 is a coronavirus. You've heard that word a lot. This is a large family of viruses, something we're actually very familiar with because it infects humans. And all of us have been infected with some coronavirus or other at some time. Now, there are many strains of coronavirus, and many of them infect humans, mammals, and also birds. And in some instances, these animal coronaviruses can infect humans. And 2 things I want to talk about with the virus. One is that there are spike proteins on the surface. They make them look like a crown. Here's an electron micrograph picture from the CDC. You can see the crown around the virus. And that gives it the name coronavirus. Corona means crown. Here's a diagram showing the crown, which is actually spike proteins, which are on the surface and important for the virus to attach to human cells. And the second thing to know about is inside the virus is RNA. That's the genetic material for the virus. Now, coronaviruses cause respiratory infections. Those are infections of the lungs. They're especially common in children, but also they cause about 10 to 30% of the common cold. So it's the second most common cause of the common cold. And that's why I said most of us, all of us have been infected with coronaviruses before, but there are particular strains that cause the common cold. And there are some strains that cause outbreaks. The one we all know about is called SARS. That's the severe acute respiratory syndrome. This was an outbreak in 2003. But compared to the current outbreak, relatively limited. But there are some coronaviruses like this that cause outbreaks of serious infection. Now, we can learn a lot from the other coronaviruses, both the common cold ones and the outbreak ones, because since we're learning about SARS-CoV-2, we can draw on our experience from the other viruses to know what to expect. So one of the questions we all have is immunity. Can you be infected with the current SARS-CoV-2 and develop immunity? And we know from some of the outbreak strains like SARS and MERS, which is this Middle East respiratory syndrome and another outbreak coronavirus, that you can get immunity for 2 to 3 years. So that's helpful, that's good to know, but it's not lifelong immunity. With the common cold strains of coronaviruses, however, you can get reinfected. So when people talk about immunity, lifelong immunity from the SARS-CoV-2, the answer is we don't know yet. And there's reason to be optimistic, but also reason to think that the immunity may be only lasting a limited amount of time. We know that many coronaviruses are seasonal, meaning that they tend to cause infection at a certain time of the year, mainly winter. People have talked about this, hoping that maybe the current outbreak will go away during the summer. An important point is we don't have good treatment or vaccine against any coronaviruses. And this is important as we try to anticipate what we'll have available to protect ourselves. There is no vaccine against coronaviruses. So as we undertake the efforts that you're going to hear about today to develop a vaccine, realize that there is no example out there of a vaccine to protect against a coronavirus. So again, these are the things, the elements about coronaviruses that we can extrapolate to the current SARS-CoV-2. So that's the name of the virus, SARS-CoV-2. It's a novel coronavirus, meaning that it's novel to humans, but it's probably been circulating in bats for a long time. We know that because bats have coronaviruses that are very similar to this one. And the virus is also somewhat related to the SARS coronavirus. A particular bat we think it comes from is called the horseshoe bat. You can see a picture of it here. What we don't know is how did this virus that's been in bats for a while cross over to humans? Now, this is a phenomenon we see all the time in infectious diseases. An animal virus will cross species and infect humans. What we tend to see is that it may not cause a lot of infection in the animal host, but because it's new to humans, we're not adapted to it, it can cause severe infection in humans. Now, I want to point out that the idea of a pandemic with the coronaviruses is not something that came totally out of the blue. After the SARS outbreak, there was a lot of effort to look for the source of that virus and also to see if there are other viruses like that. And so here's a study from 2017. It's actually a commentary in Nature, which is a scientific magazine, about a study where some scientists in China went to bat caves, tried to isolate coronaviruses from bat feces, and they found additional coronaviruses like the SARS coronavirus. And the point they said was that there could be a new outbreak at any time. And so infectious disease and public health scientists have been aware that pandemics are possible, and the two likeliest causes that we've been anticipating are either pandemic influenza or coronavirus. So again, this isn't something that's totally unexpected. We just didn't expect the scope of this outbreak. So here's a timeline of the pandemic, unfortunately familiar to everybody. So the first cases we know about are in Wuhan, China, at the end of 2019, maybe November or December. And then in 2012, 2020, January 12th, so just a couple of weeks after that, we knew the cause of the infection was a virus given the name SARS-CoV-2, and the infection was called COVID-19. Now, this is a very short period of time. For perspective, for the SARS outbreak in 2003, it took many months to identify the virus. So there's rapid spread, first to Thailand. We know that the cases were circulating probably in the US already in January. There was some returning people from China who came to the US. But we now know that the first death in the US was February 6th. This is about 3 weeks earlier than the case is known at the time. This is a retrospective case where someone who died in Santa Clara County in Northern California, testing done after they died revealed they had COVID-19. And this person had no travel history, no exposure to someone with COVID-19. So that gives us the idea that it was circulating already, at least in Northern California in February. And there's reason to believe that there's been circulation in the US sometime before that, perhaps in January. And you're going to see reports where they talk about circulation in China in late 2019, and also perhaps in other countries. Anyway, the spread of this outbreak has been very rapid. First, we heard about outbreaks in Italy, Iran, and South Korea at the beginning of March. And then during March, Europe became the epicenter. And you remember that March 19th, we had a shelter-in-place order in California. We were the first state to do this. In retrospect, California has been very proactive in some of these public health measures. But that's 2 months ago, and that's part of what you'll be hearing today. How long can people sustain shelter-in-place orders? By the end of March, we had more cases in the US than any other country. This is a dubious distinction. We still have many more cases and many more deaths than any other country. And by April 2nd, there were 1 million cases, but you can see now we're almost at 5 million cases. So we're 4.4 million cases. This is a website that is very handy. It's maintained by Johns Hopkins University, and it shows a running total of the cases. We have 1.4 million cases in the US. It also lists deaths by country. So a lot of information here. This is from another website that I like called Our World in Data. This site has information about cases and deaths. And you can see here that, again, here's the total for the world, but we lead the pack. But pay attention to countries like Brazil and Russia and Peru and India, which are the active spots now. So we have about 20,000 new cases a day, but Brazil and Russia have over 10,000 cases a day. It may be that, just as we've seen in the past, the epicenter is shifting. We can look at deaths. Again, unfortunately, we lead with over 80,000 deaths. You can see that a lot of countries in Europe had a lot of deaths, but their outbreaks are settling down. And again, countries like Brazil, India, and Russia, the death rate is climbing. Focusing on the US, again, 1.3, now 1.4 million cases. Our curve has flattened, but it hasn't gone down. There are many countries where there was a peak and then the cases have gone down. And if you believe the data or the records, the cases have gone away. We have flattened the curve. Our curve has not gone down. We still have circulation. And we're at 84,000 deaths. There's a lot of reason to believe that the total number of deaths is actually higher than that. And this map from the New York Times shows where the cases have been in the United States. So as we know, lots of cases in New York City, but the entire Northeast, outbreaks in certain big cities like Chicago and New Orleans. On the West Coast, we've been relatively spared. We do have a number of cases in LA, but the West Coast really has very few cases compared to the rest of the country. Focusing close at home in Orange County, we have over 3,000, almost 4,000 cases, about 80 deaths. We're averaging about 100 new cases a day. For perspective, this is actually not a large number given the size of our county. California has 71,000 cases, and there are 1,700 cases a day. So in fact, comparing to neighboring counties, the death rate in Orange County is actually on the low side. Now, one of the issues is the number of cases. How accurately does it reflect the number of true infections? Is it due to more or less testing in your area? And so what I look at is the number of cases in the hospital, because that should really be a reflection of the true number of severe cases. So the Orange County Public Health Agency, which is Orange County Healthcare Agency, which is our public health department, has a very good website, and they list daily information. And here they show the number of hospitalizations in orange and number of intensive care unit cases in blue. And you can see there's a general increase, but no spike. Okay, and that's the thing to look for when we look to see what's happening nearby. Do the orange and blue bars stay about the same? Do they get bigger? Here I'm presenting what the infection looks like. And so we have someone who is exposed, and then 4 or 5 days later have onset of symptoms. And the most common symptoms would be fever and dry cough, which means a cough, but the person isn't bringing up any sputum, and fatigue. So this is common in a lot of patients. Fever would be 80 to 90% of patients. And then there are many other symptoms, such as loss of appetite. Some patients actually bring sputum up when they cough, or muscle aches. And you may have heard that some patients have been reported to have disorders of their sense of smell or taste. So in mild cases, this continues, and then the patient recovers after about 2 weeks. And I mentioned that the incubation period, or the time between exposure and symptoms, is thought to be between, on average, 4 to 5 days, but can be up to 14 days, which is why you may have heard when they talk about quarantining exposed individuals 14 days, that's where the number comes from. But on average, people develop symptoms within 4 to 5 days. Now that brings up an interesting point, though, which is when are these infected individuals infectious? When can they pass it on to someone else? And for a lot of infections, people are infectious when they have symptoms. But you may have heard that with COVID-19, the reports that people who are quote unquote asymptomatic without symptoms can be infectious and can spread the infection. And so now we know that individuals infected can have virus and shed virus for instance, in respiratory droplets for 1 to 3 days before they have symptoms. So the peak viral load or amount of virus in their respiratory secretions is about a day before they have symptoms. And so the worrying thing here is someone doesn't know they have symptoms, they're still going about their normal business, they can expose other people and infect them. And so this infectious window is the thing to be concerned about. People are infectious, we think, for about a week. And so we have documented cases of individuals who haven't had symptoms yet, were infected, spread it to other people, and then develop symptoms later. So this we call pre-symptomatic. It falls under the general category of asymptomatic spread, but these individuals are pre-symptomatic. They're going to have symptoms, they just don't have symptoms yet when they have already spread it to someone else. So this is a mild infection that we talked about. About 80% of the cases with symptoms are mild, but about 15 to 20% have the same course initially, but then take a turn for the worse. So we call these severe infections. The initial presentation is the same with fever, dry cough, and fatigue. But after a week, they have shortness of breath, and this can be worse with exertion. And they go to the hospital and are admitted usually about day 7 or 8 after symptoms. And it's so far hard to predict in the early stages who is likely to go on to severe infection. These patients can have ARDS, which is acute respiratory distress syndrome. This describes a difficulty in their lungs providing oxygen to their body. They get admitted to the ICU, they require ventilation, a mechanical ventilator. And on average, if some of these patients die, they will die at day 18. And as we've seen in the US, about 6% of cases, symptomatic cases, end in death. A quick word about shortness of breath. This is an unusual feature of COVID-19 infections. It tends to occur at the end of the first week, and it's because the patient's air sacs or alveoli in their lungs fill up with fluids. There's inflammation around the alveoli, and this impairs the oxygen uptake. A very quick point about asymptomatic infections. So the issue at hand is we know that many cases are symptomatic, but we don't know how many cases are asymptomatic. So are we talking about a small number at the base of the pyramid or a very large number? Now, if there are many asymptomatic cases, that's good and bad. It would tell us that there are a lot of mild cases. It would tell us maybe there are many more cases in our community. So we don't know yet how many cases are asymptomatic. In terms of who gets severe infections, there are some known risk factors. Most prominent is age. Individuals over 80 account for over 65 account for 80% of deaths, and you can see here the hospitalization rate increases with age. You've heard about underlying medical conditions. If patients have cardiovascular disease, so heart disease, diabetes, hypertension, obesity, these predispose individuals for more severe infection. I'm going to finish up with some words about transmission. The transmission is mainly by respiratory droplets. This is a respiratory infection. These droplets contain the virus. They're produced by coughing and sneezing, but even talking or exhaling can produce the droplets. And there's been work looking to see how far these droplets go. And the work has shown that most of the exposure is within 6 feet, which is where you get the rule about staying 6 feet away. And the spread is when these droplets contact the mouth, nose, or eyes of another person. So that's a direct spread. You can also spread person to person via hands, so with handshaking, and that's when the infected individual gets respiratory droplets on their hands, they shake hands with another person, that person touches their face. But we're also concerned about transmission indirectly via contaminated surfaces and objects. This is why people are concerned about going outside and touching things in common with someone else. And so objects can be contaminated with respiratory droplets, but the thing to know is that in most cases, the virus contamination is low. It's only in certain cases where there's a lot of virus can it last a long time and spread. So this is most likely in certain situations in an infected individual's household or in their room in the hospital. So remember that spread indirectly by contaminated objects is really much less common than spread by respiratory droplets. And then with asymptomatic spread, I already mentioned spread by pre-symptomatic individuals who don't yet have symptoms. But the other thing we're concerned about is what about those patients who never develop symptoms? Can they spread infection? And the answer is we don't know that yet. All right, well, that is my talk. Thank you, and I'm going to pass it on back to Eileen.
Fantastic. Thank you so much, Ming. Again, I just want to remind the audience tonight that I do see some questions coming in. That's fantastic. We really invite your questions. We want to be as informative as possible, but we are going to hold them and try and ask out to the speakers at the end, and I'll be moderating that. So please stick with us till we get to that point. Now I'd like to introduce Dr. Ed Monuki, who is going to be speaking about the current status of testing for COVID-19. Ed has his bachelor degree from MIT, an MD and a PhD from University of California, San Diego. At UCI, he is the professor and chair of the Pathology department. He's the director of the Neuropathology Core for the Alzheimer's Disease Research Center. And he also, most importantly, in some ways for his role this evening, is two other things. One, a very valued member of the Stem Cell Research Center here, and also the director of the clinical laboratories, the clinical testing laboratories at UCI, and hence his role in talking to us about the status of testing for COVID-19. So Ed, please, if you would share your screen and take it away.
Great. Thank you, Eileen, and thank you all for joining this evening. So I'm going to try to keep this relatively brief and focus on what I hope is the most practical information about the tests. And one of the facts I think that is often confused is that there's actually two tests. And sometimes we think we're talking about one when we realize we're talking about the other. So hopefully by the end, I'm going to lead off with a punchline, if you will, that there are two tests. They have different purposes, different meanings to both us as a society, but also as you as an individual. There are different issues surrounding both of the tests, but importantly, both of them are going to be very important for us as we return to some semblance of normalcy. So I'm going to describe the two tests in the context of the natural history of the disease that Ming just spoke about. And we start off with the infection. And the first thing that really happens is that the virus starts to grow, divide, multiply in the body. Typically, the body does clear it by about 2 weeks. And so this is important for thinking about the first test. Soon thereafter, during the first week, symptoms begin, and that's about the time that the body and the virus also start to make a number of viral products. And these products, sometimes called antigens, are the ones that stimulate our natural defense mechanism, which is the production of antibodies. And you probably have heard about two different kinds of antibodies, one called IgM. That's the one that comes up first here in blue. That tends to taper off and can't be detectable in the blood after some time. And then there's the second antibody, the IgG, shown in green, that comes up a little bit later, but tends to persist for months and in some cases years for viruses. And so the first type of test is what I'm going to refer to as a PCR test. That stands for polymerase chain reaction. That's the Nobel Prize winning technology. That's a basis for detecting the virus. you might hear in the media, it's sometimes called the molecular test or the diagnostic test. Now that's useful when there's virus to detect. So it's really useful in that early phase of the disease. Then the second test you're going to hear about are the antibody tests, sometimes referred to as the serology test. And that's intended to detect the antibodies, either IgM or IgG, and that can be useful in the later phase of the disease and can be useful for a lot longer, as long as the antibodies are detectable. Okay, so I'm gonna sort of organize this around sort of frequently asked questions. And so what is the PCR test useful for? Well, first off, just wanted to clarify that those two tests require actually a different kind of specimen. So the PCR test, typically you get a swab. So a swab of the nose or the back of the nose, maybe the back of the throat. The antibody test requires blood. Okay, so just want to make that clear so people understand what they're doing when they're asking for a test. The PCR test answers all those questions on the left. Are you infectious? Do you need to quarantine yourself? Do you need to watch out for symptoms if you're getting sicker, as Ming mentioned, and think about whether you need to potentially go to the hospital? And very importantly, for getting back to normal is this concept on the bottom of contact tracing. So that's the idea that once the curve does go down, that once we identify people who do have COVID disease, so we want to be able to test them quickly, quarantine them quickly, identify who they might have had contact with, and get them tested and potentially quarantine them. That's the idea of contact tracing. That's what the PCR test is useful for. And the antibody test is actually not useful for answering or addressing any of those issues. So what's the antibody test useful for? So it has its own utility, right? So it answers the question, did you have COVID in the past? Okay. It also answers an interesting and sort of a, if you will, a generous question is, can I potentially help somebody who has COVID now? And that's the idea that people who are positive for the antibody may be potential donors of what we call convalescent plasma that can be used to treat somebody who's very sick with COVID now. Does it help us understand prevalence? Yes. So this idea that we've undercounted and have not been able to identify who has the disease, and that's the idea of prevalence, and antibody is the test for that. Then the last two on the list are the ones, again, that get us back to potentially towards a normal life. Does the antibody test, are we immune to COVID? Meaning, are we protected from getting the disease again? We hope the answer is yes, but right now it's still a question mark. And then finally, if enough of us have that immunity, so-called herd immunity, which will be in the case, did the vaccine work? The antibody test will be the one that helps us answer that question. And so those are the $2 million questions right now. Maybe if you think about the economy, maybe the $1 trillion questions, because if those become yeses, then we have a pathway to getting back to normalcy. So when should you get each of the tests? Hopefully it's clear now. The PCR test you should consider as the early test when you're infectious. The antibody test is the one late that hopefully means that you might be protected from getting the disease again. So a very frequently asked question is, why are we not testing more? And this is just a partial list of the reasons. And I broke it down again according to those two different kinds of tests. Obviously, we, the entire nation, got off to a slow start. In addition to that, there were just a myriad shortages that were impacting the ability to bring up the testing. Eileen brought up one that the Stem Cell Center was incredibly helpful for, which was manufacturing the transport fluid for those swabs so we could actually do the PCR test. And unfortunately, that shortage situation created a competitive environment where every clinical laboratory, every hospital, university, health system, states, and even governors were really competing against each other to get the reagents to do the testing. it created an environment that I just have never experienced myself. And I think is one of the consequences of the lack of overall coordination of the response. Because of that too, did we have to prioritize speed over quality of the tests? Yes. And really, did the FDA have a choice? No, they had no choice. They needed to release tests, get them approved quickly, more quickly than they would like, because we needed to make some testing available. So are there bad tests? Fortunately, it's mostly, it's a yes and no for the antibody. For the PCR test, the answer is basically no. The tests that are out there are good tests, quite sensitive and specific. The antibody test, it is a mixture. So fortunately, as we are kind of maturing in our response to COVID-19, the tests are better and better. The yes has to do with the fact, again, the FDA had no choice. They allowed antibody testing without their approval. So it created what many have called the wild, wild west in the antibody testing market. Some referred to it as the wild, wild east, because most of those tests were coming from overseas. And many of those, time has proven that they are not great tests. But fortunately, many of the other tests are seeking approval from the FDA, are receiving those, and those are the ones, of course, that we are bringing online at UCI and at other clinical laboratories. So the good news is, are we catching up? Yes, we're catching up with the manufacturing. The shortages are starting to resolve. The competition is becoming a little bit less. Things are getting a little bit more coordinated, and quality is starting to come in over speed. Okay. Does that mean there are no problems with the test? No. And you know, as a clinical laboratory director, there's no such thing as a perfect test, right? So there are always issues with accuracy, but of course you want to minimize those as much as possible. So with the PCR and antibody tests, there's this issue of false negatives, that you actually have the disease or you actually did have the disease a while ago, but the test comes out negative. And there are several reasons for that, right? And actually, most of the time for the false negatives, it's not the actual test itself. It's actually the timing of the taking of the sample. I think, as I showed you in that natural history, there's only a short period when you can really catch the virus. We're only sampling one part of the body, the nose or the back of the nose, typically. And sometimes it's hard to actually get a really good specimen from the back of the nose. And then the timing with the antibody, again, it needs some time to generate detectable levels of antibody in the blood. And so a lot of them have not really as much to do with the test, just as sort of the natural history of the virus and challenges in sampling. False positives, generally less of a concern. Again, the PCR tests are quite good, and the good antibody tests are quite good. But the bad antibody tests are not so good. And again, so the test quality has been one of the issues for the antibody test. Okay. So what are we doing here at UCI? This is a brief list about the tests per day in terms of our capacity for the PCR tests and the antibody tests. We are, of course, very focused on taking care of our patients that need to come into the hospital. So we need to have a more rapid turnaround time, as they say, with the testing for our patients in particular. And so we typically are able to deliver the result in less than 24 hours. Has this been enough? Has this been enough for us to allow us to reopen the hospital? Yes. And so we're very actively reopening the hospital, taking care of the patients who have non-COVID conditions, who've been waiting to get their care because of the COVID pandemic. And fortunately, we have been able to create a safe environment for them to come back to, and business is really starting to come back towards normal. Is this enough for us to be able to start helping outside of UCI, other parts of Orange County? And we have absolutely been able to help others do testing there as well. Is it enough to reopen UCI campus in the fall for our 20,000 plus students and all of Orange County and the companies that would like to get back to business? So no, that's not enough. Fortunately, we're not the only testing laboratory in the area, but even then, we all need to continue to look to build more capacity. And that's what we're doing, both for the PCR testing and for the antibody testing as better and better tests come online. I want to give a shout out to the microbiology team led by Dr. Cassie Bittencourt, who really were amazing heroes in my eyes in bringing up all of the different PCR testing platforms for us at UCI. And then a shout out to our chemistry team. You could see the PCR test came up before universal masking was implemented. The antibody test came up after. The chemistry team led by Dr. Bridget Cruz and our CEO, our new CEO, Chad Lefteris, who came by to thank the team. And I want to give a special shout out to them. So ending with the punchline, remember there are two tests. Somebody starts asking you questions about the test, or you start reading something about the test. The first question you should ask is, which test is it that we're talking about, right? And again, both of them have different purposes, but both of them will be very important for us to get back to normal. And with that, thank you for listening. I'll hand it back to Eileen.
Ed, thank you very much. So the third panelist that we have presenting tonight follows on from Ed, because her expertise is really in the area of thinking about biotechnology and global health policy. And so this is going to be the topic of her talk, Bioethics of Reopening Society in the Middle of a Pandemic. With that, I'd like to introduce Michele Bratcher Goodwin. Michele is a Chancellor's Professor of Law and the Director of the Center for Biotechnology and Global Health Policy here at UCI, again, a co-sponsor of our event, our virtual event tonight. Michele received her bachelor's degree at the University of Wisconsin. She attended the Boston College for her law school degree. She was a postdoctoral scholar at Yale, a fellow at the University of Rome, and before she arrived at UCI, the Edward Fraser Professor at the University of Minnesota in their law school. So Michele, welcome, and please take it away.
Thank you so much, Eileen. It's such a pleasure to be with you and to co-sponsor this event with our Stem Cell Research Center. I think this event is so important, not just for our local Orange County community, but beyond that. And so I'm going to be talking about bioethics and reopening our society. And when we're thinking about bioethics, one might wonder, why is it important at all? And this talk is going to cover three broad themes. One, what authority does government have? Two, what are the limits of that authority? And three, what ought we to be thinking about given the talks that we've heard and the talk that you'll hear from me this evening? You won't have to worry about any slides. This is going to be low tech. All right, so when we think about where bioethics principles emerge from, in some ways we could say that these are principles that emerged from thousands of years ago, that they're not exactly new at all. But Nuremberg really instantiates how we understand modern bioethics, not only in the United States, but in the world. And it was in 1947 that there was the doctor's trial in Nuremberg. That is because what went on in Nazi Germany, much of it involved horrors that were taken out within the space of medical science and research. The culmination of the trial against the doctors was very interesting, because one of the defenses of the Nazi doctors was that they were doing nothing different than what was being done in the United States. And I'm going to talk about that briefly in a moment. But that was 1947. And out of that came a number of principles, but there are about four that really help to instantiate much of what we mean when we talk about bioethics. And that includes principles of autonomy, beneficence, non-malfeasance, and social justice. And when one thinks about why they're important, it's because medical scientific research and sometimes the problems that go along with them were not contained in Nazi Germany, not at all. In fact, when the Nazis said, you know, that we learned from you in the United States, they were speaking specifically to eugenics. It was in 1927 that the United States Supreme Court permitted eugenics to flourish in the United States. There was a Virginia law, a model Virginia law, that provided for the forced sterilization of people who were considered to be socially and morally unfit. In that case, Justice Oliver Wendell Holmes said that 3 generations of imbeciles are enough. Shortly after the United States Supreme Court upheld this model law, it made its way to Germany. And at a certain point, US legislators said that the Nazis were beating us at our own game. You know, this is a part of history that we tend to ignore in the United States, but it is exactly what the doctors in Nazi Germany were referring to. And it's true that we actually hadn't learned our lessons from that, because one of our key experiments that's pointed to when we reflect on how the US has in ways abridged its kind of moral authority is with the Tuskegee experiments, where for more than 40 years, the United States government, along with certain medical institutions, were engaged with research on illiterate men in the South, men who the government said they were providing medical care to, but really weren't. They were providing sugar pills to these men who had syphilis. The government encouraged these men to carry on relationships with their spouses. They had children born with congenital syphilis, which can lead to blindness, paralysis, etc. The study went on for 40 years, even after it was known that penicillin cures syphilis. Each year, the government would send a certificate to the men in the study saying what a good job it was that they were doing by being in the study. It was a New York Times reporter who broke the story, and even after she broke the story, there were researchers in government and also at medical schools that wanted to persist with the study. This gives you some idea about why we should care about these issues. But when we think about what authority does the government have and how that interfaces with bioethics, many people wonder, well, do governors have the authority to impose certain types of restrictions, such as sheltering in place or quarantine? And the truth of it is they do, dating back to a 1905 case, Jacobson v. Massachusetts, where the United States Supreme Court upheld a local law, a law that was in a municipality in Boston that provided for vaccination against smallpox. There was a person who sued so that he would not have to receive this vaccination. The United States Supreme Court in Jacobson v. Massachusetts said that a local authority has, in fact, the authority to impose such conditions on its citizenry so as to protect public health and safety. We call this a parens patriae authority, which is basically that the government is able to act in some ways euphemistically as the parent of people in its area to protect those people. Now, are there limits to this government authority? Yes, there are. But if you think about issues such as vaccination, then you can see very clearly that the government can impose conditions on people, even as intimately as relates to their bodies. But that authority is not absolute, and I'm going to talk about that. But before I do, it's important to know that the government's authority in this way must in fact be balanced, right? So that is very important that we're guided by health and science when government is seeking to protect the public health. Now, in these days, issues have come up because of sheltering in place. And what you've heard from my colleagues is that California was ahead of the curve. And for that reason, you do not see an outbreak in California as we've seen on the East Coast, because California led the country with a shelter-in-place order so as to minimize the potential spread of this novel coronavirus. Governor Newsom had the authority to do so, but you see across the country that there have been challenges to the shelter-in-place orders. You see in some instances where there are local mayors that had shelter-in-place orders, such as in Mississippi, where the governors have then said, you know, I don't believe in that, I'm lifting it. You've seen in the state of Wisconsin challenges that have gone up to the US Supreme Court. There are fundamental questions about, well, what is essential during these times? You've seen that play out. In Texas, there have been questions about what's essential, where the governor has said, guns are essential. Purchasing ammunition is essential. A woman's reproductive health care and being seen by her physicians is not essential. Some have said that this is a time in which politics have come into play, and in fact, where the pandemic is being used for political purposes. One might say that that's playing itself out in very clear ways when it comes to reproductive health care and rights. But there are real questions about, well, is it essential to be able to go to worship on a weekend when social distancing is very difficult, if in fact almost impossible? In Wisconsin, people have said going to bars is something that happens to be essential. You see across the country these kinds of questions being debated. But what is clear is that unless a state's legislature has somehow usurped its governor's authority, the governors have the authority then to impose certain conditions that are measured conditions that relate to protecting the public's health. But we see challenges to that as well. In Wisconsin, just yesterday, the Wisconsin Supreme Court overturned that governor's extended sheltering in place order. Just a couple weeks before, the Wisconsin Supreme Court, also along political lines, I should say, that this was a decision that was part of an ideological split. A few weeks ago, again, along lines that were an ideological split, the Wisconsin Supreme Court overturned another governor's order, overturned that governor's order, and that order was in fact to extend the election time. What we do know is that with that election going forward in Wisconsin, that there were at least 70 people who contracted COVID-19 going out to vote in Wisconsin. And so it's important to think about how courts also relate to these questions. The US Supreme Court even got involved with that Wisconsin Supreme Court election debate. And that is the US Supreme Court, again, split along ideological lines, overturned a district court's order that would have allowed for an extended time period for absentee votes to come in. What Justice Ruth Bader Ginsburg wrote in her dissent was the following: about 1 million more voters have requested absentee ballots in this election, more than 1 million than in 2016. She said, "I fear this will result in massive disenfranchisement, not counting those votes. A voter cannot deliver for post-marketing a ballot that she has not received." And what she was referring to is that so many people wanted to stay at home and protect themselves that they opted to vote by mail. But there were so many who chose to do so that the state just simply couldn't keep up. And she said tens of thousands of voters who timely requested ballots are unlikely to receive them by the date of the election. She concluded with saying either they will have to brave the polls, meaning people in Wisconsin endangering their own and others' safety, or they will lose the right to vote through no fault of their own. That is a matter of utmost importance to the constitutional rights of Wisconsin citizens, the integrity of the state's election process, and in this most extraordinary time, the health of the nation. But what about when a state does too little to protect its citizens? Well, there's been litigation in that regard. In fact, that type of litigation has been framed as a violation of a civil right when a state does too little or shows indifference or indifference to the regard and the health and the safety of its citizens. So one aspect that I want to cover with this, and it was just alluded to a bit, and that is our preparation to deal with this. What is known is that even weeks before the 2017 inauguration, it was very clear, in fact, that there would be the need for a pandemic team, and in fact, that there might be a pandemic that might arise within 5 years. We're right in the middle of that particular time. And it's worth noting that it's not as if this is the first type of pandemic of this scale. During the Obama administration, we experienced H1N1, and it's important to note that that began here in the United States. There was also Zika, and there was also Ebola. Not at the scale of what we're experiencing today, but I mentioned that only to speak to the importance of preparation and government being prepared. There's not just the authority that a state has, but there's also the responsibility that a state has. So now let me move on a bit more quickly to talk about the limits of governmental authority. Even though government does have authority to respond to health and safety, there are limits to government authority. That government authority is not absolute. We can see that in the aftermath of 9/11, where government went too far, and that is government involved itself with warrantless searches of people's cell phones and also internet use. That did not relate to dangers that had been experienced with 9/11. And so it's important to also think about how we calibrate effectively the government's response to this pandemic, meaning that the government should not try to do anything that would actually undermine civil liberties and civil rights, such as utilizing flawed facial recognition technology as a means of addressing the pandemic. That won't work. Or some of what we've seen in other parts of the world, such as in Bolivia, canceling elections altogether, in Thailand, censoring news media, in Hungary, suspending all elections and restricting freedom of speech, in Israel, ordering the closure of courts and using technology to track cell phone movement, in Jordan, restricting freedom of speech. These are the kinds of things that we want to be concerned about domestically and even abroad. Now, finally, what are the kinds of things that we should be thinking about in our country? We should be thinking about the equitable distribution of resources. One of the things that we've seen is the dramatic racial disparities in terms of the people who are dying from COVID. In fact, to think back about Wisconsin just one more time, even though African Americans comprise only 6% of that state's population, they've made up more than 50% of the people who've died. There, across the country, we've seen similar types of patterns. There are concerns about equitable distribution of ventilators and time on ventilators that we ought to be concerned about. That speaks right to the heart of bioethics concerns. As we think about vaccine development, there may be questions that arise with regard to fetal tissue research. And it's important to know that most of the vaccines that have been developed over the last century involve the use of fetal tissue research. And so we want to think about that. Patenting and vaccine. When Jonas Salk discovered the vaccine for polio, he said that he would not patent it. And he said, would you patent the sun? He says that this is a vaccine that belongs to the people. Will the vaccines that are being developed today, will researchers have the same response, that these are vaccines that belong to the people, and the importance of intergovernmental support and research for the development of a vaccine. And then finally, I want to touch on one last point, and this relates to ethics, it relates to law, and it relates to how we keep harmony in a society. And that is, early on, after it was known that we were dealing with something quite serious in COVID-19. And there were some politicians that began using the term Chinese virus, Wuhan virus. Part of what we're concerned about in bioethics as well is, in fact, the avoiding the use of kind of sexism and racism and kinds of terminologies that actually push us further away from actually getting to the heart of the matter. And that is a question with this too. Racism will not help us in achieving and working on a vaccine. In fact, it will only undermine harmony. And we've seen in the United States the effects of turning to stigma, stereotype, and racism. We've seen that with the bullying of people. We've seen that with attacks in New York City against people from Asian communities. We've seen it with the rise of hate crimes. That does not help us achieve in medicine or science. It certainly won't help us in this regard at all. And so that's something also for us to avoid, something for us to pay attention to, And I'm happy to take any of the questions that you might have with regard to bioethics or law and how it relates to this particular pandemic. Thank you. Eileen, I'll turn it to you.
Hi, Michele. So thank you very much for that thoughtful summary. And I just want to reiterate again, I am so grateful to have you as a colleague and a member of the center. This is not our first collaboration. I know it's not going to be our last, but your thoughtful perspectives, I think, are so important to bring to this discussion.
Thank you.
With that, I want to introduce our final speaker for the panel. This is Dr. Daniela Bota. Daniela, again, is a very valued colleague in the Stem Cell Research Center here. She's our clinical director for the Alpha Stem Cell Clinic, but she has many hats at UCI. She's a professor of neurology. She's the associate dean for clinical research. She is the vice chair for academic affairs in the Department of Neurology, and she's the medical director of the neuro-oncology program here. Dr. Bota received her MD in Romania, but her PhD at the University of Southern California, and then completed a fellowship in neurological oncology at Duke University. So Daniela is going to tell us tonight about what the clinical trial landscape for COVID-19 looks like. Daniela, please go ahead and share your screen and go on.
Oh, I didn't. So can you see my screen?
You're good.
Perfect. Thank you so much. Are we good right now?
You need to switch screens.
I will do it shortly. Thank you so much for having me here tonight, Eileen. It is my pleasure to talk about the activities at UCI on COVID-19 studies. It is amazing how we were able to build a whole portfolio in such a short period of time, as Professor Chan presented to us. We do believe that clinical research matters. We believe that it matters especially in the time of crisis, when our colleagues and our patients are hoping for new treatments to be discovered and new methods to prevent disease to be brought to our communities in Orange County and in the whole country. When we think about the ways on which we can fight the SARS-CoV-2, it always has to start with the prevention. And if you are exposed, to the way on which we can do post-exposure prophylaxis. So even patients that are exposed to the virus do not go on to developing the disease. And not everybody is created the same. That's why I'm showing this slide with so many people. The general population might develop very benign forms sometime of the infection. There are people that are asymptomatic carriers. We know that very few children, very few teenagers develop serious disease, though there are still some of them that had been placed on ventilators, and some of them unfortunately even died. But if we contrast this with our at-risk population, our patients on dialysis, our patients with cancer, our older patients 80 and above, we realize that maybe the measures that we take for the general population might not be the same, might need to be more defined and even more aggressive for those at-risk population where the viral infection is much more commonly associated with severe mortality and with significant disability for the patients that survive. And then there is something to say about the people that come in contact with patients with COVID-19 every day, and they get multiple times in contact with high loads of the virus. We know from China, from the European countries, that unfortunately in the medical personnel, the rate of infection, at least in the beginning, was as high as 20%. And the majority of the medical personnel was at the right age to have minimum symptoms. There's still an 8 to 10% mortality. So again, people where we want to do post-exposure prophylaxis and find good modalities to do it for each and every of the people exposed. We also heard about the symptomatic disease. So when we want to develop treatments, we would preferably like to develop treatments to stop the progression of disease. It's true that it's not fine to have fever and cough, but if possible, we would like to stop the people that have fever and cough to develop difficulty breathing. This is usually where a patient that could be at home and be on isolation needs to go to the hospital and be admitted. And even more, if the patient is admitted, we like the patients not to be placed in intensive care. We heard so much about how we have a limited number of beds. And in the beginning of the pandemics in the US, we are all going to a real panic about the need of having enough beds. And by far, we are overwhelmed by the idea that we're not going to have enough beds. And then if we have enough beds, would we have enough machines to be able to assure artificial ventilation to the patients that are not able to use their lungs to achieve enough oxygen in the air? So now the next step is you're a patient, there is a patient, the patient has recovered, it's ready to go home. But recovery is never full after this disease, not when you are already on the ventilator. By the way, only 20% of the people on the ventilator will be able to go home and resume life. But they will need follow-up, and they will need a treatment of short-term and long-term complication. And when I'm saying this is what you hear a lot right now. We have a large number of patients that have partially recovered, but the convalescence is very prolonged. And some of the damage to the lung, to the kidney, to the heart, the increased number of strokes that we are seeing, the liver damage, can be permanent. And in addition to this, we are going to one of the most serious psychiatric and psychological crises, where the number and the usage of psychiatric services have more than quadruple. So this is something that we need to consider when we think about what treatments do we need to develop for this new pandemic. I'm not going to walk you through all the mechanisms of viral infection. I think we have heard a lot, and we have heard exceptional information about the biology of the virus. But from my point of view, as a clinical scientist trying to develop treatments, the first and the easiest way on which you think about the virus is, can I stop the virus from getting into my body? Can I stop the virus from getting into my cells? If the virus gets into my cells, can I stop the virus from making more viral particles? And if I can not stop it from making many viral particles, can I stop the cells from being destroyed and putting out even more viruses to infect other cells? So the first process that we are talking about, which is the inclusion of the virus on the cell, is called endocytosis. And there are some drugs of doubtful benefit that a lot of people heard about, chloroquine and hydroxychloroquine. But there is also a new generation of drugs that I'm going to talk about a little bit. One of the most promising one in clinical trials being the baricitinib. So what you see in blue here, just to make a convention now, are treatments that we are actively researching at UCI in clinical trials. Those are treatments that are either available tonight for people in our hospital to have the opportunity to choose to participate on clinical trials using those drugs, or drugs that will be physically available starting next week. The first story that I want to tell you, I'm sure that you are very curious to hear about, is the story of the remdesivir. And this was the first drug that the FDA approved in order to lessen the consequences of COVID-19 disease. And this drug blocks the replication. We are also looking at a new molecule, so new that it doesn't have a name, has only letters, BLD2660. And this molecule also will block viral replication. So you see here that we are looking at different categories of drugs and hopefully they will work better together. Because what if we block part of the getting the virus in the cell, but not all of it, because no drug is perfect, but then the drug that gets in the cell cannot replicate. That would be a 2-for-1 treatment. So let's go to the remdesivir study. We are one of the main centers participating on the seminal study that got the data needed for the FDA to approve the use of the remdesivir in patients. We have started this study in an amazing amount of time. Usually to open a clinical trial with all the rules, regulations, with considering all the ethic aspects takes up to 90 days. We have opened the study in 13 days and we have recruited in the last 3 weeks 27 patients. On the week of 7/27, we have moved from having the study offering only remdesivir to offering the remdesivir in combination with a second drug, the one that I mentioned, the baricitinib, which blocks the takeout of the virus into the cells. I think it was so wonderful to have finally clinical research being highlighted at TV. And here you could see our clinical investigators, Dr. Shea, Dr. Amin, talking about this study and talking how a drug that partially failed treating Ebola, it's actually a very effective drug to treat COVID-19. So in a nutshell, Dr. Fauci says very modestly that remdesivir shows quite good news and sets a new standard of care. What happened was this drug, the time of recovery, the time of getting out of the hospital was 11 days for the patients treated versus 15 days for the patients that were not treated with this group. Also, the mortality was 8% for the treatment versus almost 12% for the patients that were treated to the placebo control. To the level that right now you cannot run a clinical trial on COVID-19 disease where you use a placebo. All the studies now, they are based on all the patients getting remdesivir. The drug was approved on May 1st, and now there is a great effort in the nation to make enough drug and to distribute it to enough patients to be able to have access to the drug. And this is another ethical problem that Dr. Goodwin, I'm sure, will be happy to discuss with you. When you do not have enough drugs, what are the ethics of deciding to which patient you give the drug first? So we don't need to treat only the virus, we need to treat the symptoms. If the patient already develops problems with their lungs, they need to be intubated. They get this very bad type of pneumonia. What can we do to help that patient have better oxygenation, bring more blood to the lungs, and then get more oxygen from the lungs in order to continue feeding the brain, feeding the liver, feeding even the lungs? So the study that we are opening this week, it's a study of aviptadil. Interesting enough, aviptadil was developed in Europe to treat erectile dysfunction, but through its mechanism, it also protects against pulmonary edema. It protects against that terminal condition on which patients get on the ventilator and many times don't ever get out of the ventilator. Another drug that we are working on, again, a letter drug, it's PUL 042. And this drug is trying to work even deeper, creating an immunity, stimulating the body's own immunity to try to convince the body to start fighting the virus once the virus is infecting the organism. Now we're going to go to what is a good part of this talk, but also a lot of the focus of the work that we do in the Alpha Stem Cell Clinic, which is the clinical trial arm of the Stem Cell Institute. And much of our work is sponsored by CERN, by the California Institute of Regenerative Medicine. Even the existence of our clinic is based on a grant that we have received from CERN, and which made possible to bring a lot of the work that you're going to see now to UCI and to Orange County. The first treatment that, again, you are very familiar with, and I want to talk to you a little bit about, are the convalescent plasma antibodies. The idea with the antibodies is the antibodies will bind the virus and will block the virus to come and invade the cells. We can do that using all the antibodies from the blood, or we can start purifying specific antibodies. And here there is a monoclonal antibodies that comes purified from different organisms, and it can block mechanism of activating inflammation in the cells. And by blocking inflammation in the cell, you will also block the worsening with pulmonary edema, the coagulation in the blood vessels, and try to carry the patients through the most acute part of the disease. I also want to talk to you about two projects on which our scientists and our collaborators from neighboring companies are involved together. One is the production of the dendritic cell vaccine in order to create immunity against SARS-CoV-2 virus, and another type of project, which actually we have a number of companies working in different directions, and we hope that one of them will be successful, to use mesenchymal stem cells and exosomes derived from mesenchymal stem cells to reduce the inflammation and increase tissue repair. Convalescent Plasma Bank at UCI, it's again funded by CERN. And this was of an important help, because what we know right now is that the convalescent plasma, it's a treatment, many times the only treatment that the patients can access. I mentioned the remdesivir as being a good treatment, but remdesivir is not available, by example, for patients with renal dialysis, because it becomes toxic on their body when the kidneys cannot detoxify the drug. Also interacts with some of the cancer treatments. So those patients also benefit of convalescent plasma. But when you collect plasma, it's the same as collecting blood. You want to be able to collect from as many as possible donors, and donors are patients that were previously infected with COVID-19, and now they're available to donate the antibodies that will be purified from their blood. But you want to have very diverse people, because we are coming from diverse ethnic backgrounds, and you want to have the possibility to treat each and every patient. So anybody that wants to find out more about it, please let us know. If you want to be a donor, that will be greatly appreciated. Dendritic cell vaccines were used extensively in cancer research. And the idea is that we have those immune cells that can be used to produce an immune response in the body. So what if we get the dendritic cells and we condition them in the dish, we present them in the dish with fragments of multiple strains of the SARS-CoV-2 virus, and then we repurify the cells and we give them back to the patient that we are trying to immunize. We will be able to transfer now the knowledge of the dendritic cells to the patient's body without transferring the virus. And we can theoretically create both B cells that are going to create antibodies against the virus, and hopefully T cells, which are the cells that attack the virus and try to destroy it. We are right now embarking in a common project with Ivita Biomedical, designing a very large study. It's going to be a safety as well as an efficacy study, and we'll let you know as soon as we are ready to call for patients, especially volunteers that want to participate on this study. I'm going to close talking about mesenchymal stem cells. I know that you have seen many of our lectures, but for the people that maybe are here for the first time, I want to remind you that the mesenchymal stem cells are able to differentiate into a variety of cell types, including bone cells, cartilage, muscle, and fat cells. And because they have those properties, they can differentiate and they can regenerate different tissues. But interestingly enough, they also have an ability to interact with the immune system, and they have immunomodulatory effects and antimicrobial and antiviral effects. This is why they are considered for many potential use in patients already affected and carrying body damage from the infection from the COVID-19 infection. The exosomes are fragments of the mesenchymal stem cells. They are very specific fragments, and they are very good at communicating intercellular. The part that is important for us is that they can modulate the immune response, especially that over-exaggerated immune response that's called the cytokine storm, which has a great importance in the generation of pulmonary edema and making the patients ventilator dependent. So we hope that the use of exosome could prevent the cases that will go to the patients to go to ventilator. And we hope that will help prepare the lung tissue and increase the chance of recovery for patients already placed on ventilation. This project is still on animal data. We need to learn more and to do more in order to understand what is the right place for the exosome in potential clinical trials in humans. However, the mesenchymal-derived stem cells are adopted by a large number of companies, which are right now conducting FDA negotiations and very careful evaluation, both by the FDA as well as our UCI research offices, to make sure that we understand which one of those treatments might be more promising and which one of them we will offer to our patients. Remember, like we always tell you, we want to bring the best of the best clinical trials at UCI after we carefully vet them and we make sure that there is a very strong scientific underpinning and good safety data. I would like to close with the hope of, even in the new world of COVID-19, we are developing therapies both to prevent and to mitigate the effect of infection. And we are here for you at UCI to lead local, regional, and national effort on the trials and to collaborate in the international efforts. With that, I want to recognize our funding agencies, starting with the California Stem Cell Agency, all our wonderful donors that have donated for COVID-19 research, until now more than $2.5 million dedicated to basic translational and clinical research. This makes our research possible. To recognize our Alpha Stem Cell Clinic, together with our collaborators at UCLA, and of course, our Stem Cell Research Center. Thank you so much.
Thank you very much, Daniela. I just want to take a moment and really thank all of our panelists tonight. I think the diversity of topics that was covered was really terrific. We have had, if you can all stick with us for 20 minutes or so yet, we've had some really great questions come in as you all have been speaking tonight. So I'm going to try and mix this up a little bit in terms of moderating them and hit a couple that are just very practical, granular questions. And then we've really had some terrific questions on a sort of broader societal level. So while we hopefully still have quite a few people on, one of the early questions that came in is a question about masks and masking, and what the practical realities of that are, given that there has been some sometimes conflicting information that is out in the area. I'm going to ask Ming and probably Ed to take a secondary stab at this. The question is, how is it that a mask can prevent spread to others, but not necessarily to you? And I think a good understanding of that would probably be very practically helpful for people in the community to think about what they need to do in terms of protecting themselves and others. And then a follow-up question to that is, if masks are really important, why aren't they just widely available? Why doesn't everybody have masks to be able to work with right now? And I understand that's complicated, but I'm going to toss them out to you both together. So Ming, if you could start by fielding that.
Sure, thank you, Eileen. So the main reason we are using masks in the community as opposed to in the hospital is what we call source control. And so what we mean by that is the mask wearer is trying to prevent spread to someone else. And as we mentioned, people who are asymptomatic, or particularly people who are pre-symptomatic, so they're infected, they may cough and sneeze and produce respiratory droplets within a 6-foot range. That can be spread to someone. And so the whole point is you wear a mask to minimize the chance of spreading to someone else. So in a way, you're doing a good deed for someone else. Now, at the same time, those cloth masks or the regular masks that you see that people wear can provide a certain amount of protection to the wearer, but it's not a tight seal. Okay, and so if someone still coughs in your face, you can still be exposed. You can also get it in your eyes, and you see people wearing masks and they don't cover the nose. But the main thing is you're wearing the mask to protect others. Okay. Now, having said that, there are the N95 masks we've heard about. Those are tighter fitting masks. Those are masks that we use for airborne transmission, something like TB. It's controversial, but there doesn't seem to be transmission in the community by airborne transmission. And so there's no reason to wear N95 masks in the community. Now, there's a different situation in the hospital. In the hospital, there's some things we do that can actually generate these aerosols. And there, the healthcare workers have to wear masks for protection, for self-protection, okay? But remember that in the community, you're really wearing masks to protect others. And then I think the other question you said, should there be more masks supplied? I think this is a reasonable question. We talk about personal protective equipment, PPE. And one of the things that UCI Medical Center did from the very beginning is to say, we cannot go overboard with using these masks and PPE because we have to stay prepared for the long haul. There's been talk about what we call a second wave. Maybe we have more infections in the fall, like the influenza pandemic in 1918. There was a first wave in the spring, but a much bigger wave in the fall. And so if we use all our PPE up now, we may not have it for later on. So just because you have it available doesn't mean we should be using them and running out of them later on. So I would say that's why you'll see recommendations to use a cloth mask that you can put in the washing machine and reuse.
Ming, that was terrific, I think. Ed, maybe can I ask you to follow up, because I think you've been so embedded in the supply chain issues because they pertain to testing as well. Maybe take the second piece of that and cover a little bit in as much as you can. Why is it that our supply chain, even for things like masks, has been just so challenging and kind of added to our complications?
I think the magnitude of the pandemic, of course, caught people off guard. The manufacturers of the masks, the other types of personal protective equipment or PPE were really caught off guard, and they just simply couldn't keep up the supply. And again, because of the shortages, there was competition, and there was what we call federal diversion. So at some time, FEMA was directing the PPE to the places that really needed it the most, and we were fortunate in some ways that we didn't end up needing as much as, say, New York City did. And so for all those reasons, there were those shortages. I think, again, we've had chances to catch up. There's been some very innovative, creative things, including at UCI with the production of masks. Very early on, 3D printed face shields were coming out of UCI campus to help us at the medical center. So there's been a lot of creativity and innovation as well that's been helping to address that. And then masks should be more and more available for people. And I would echo everything that Ming said about that. I think the one aspect of the question was, why is it that you can still get it when you wear a mask? I think it's, again, having it from your hands. Somebody referred to the hands as the limousines for coronavirus and other pathogens. It's easy to forget you have the mask on. You touch some surface that's infected and you touch your face. And I think on average, people touch their face something like 30 times a minute. It's something crazy. Anyway, it's hard not to touch your face. And then that's how you can get infected.
And could I add one last thing is, you'll see behavior from people. People wearing a mask have a false sense of security. So you go to the grocery store and people are wearing their mask and they're not keeping the 6-foot distance anymore because they think, well, I'm safe, I'm protected. But a regular mask will provide a certain amount of protection, but not complete protection. And as Ed said, you'll also see people wearing gloves and then touching their face with their gloves, and they can spread it to themselves that way.
Yep. That's great in terms of, I think, helping people to understand and clarify. I have not exactly a linked comment, but what I want to get to while as many as people as possible are still on. And it speaks to one of your slides, Ming, but then Michele, maybe you can be listening and be prepared, because I think it's going to make sense for you to be the follow-up person to chime in here. And the question is referring to one of the early slides you showed, where Orange County seems to have been plateauing, but the question raised is what the infection rate is looking like in areas across the country that are now starting to reopen. And do we know anything about that? What's the factual data? Because I think there's a lot of anecdotal data that's coming out, and we've seen over the last weeks that those two things are not always aligned. So if you could comment on that. And then Michele, I think this really directly bears on some of your comments in terms of thinking about how do we protect and think about society on a larger scale. So Ming, if you could start.
Yeah, so the somewhat puzzling thing is in California, we were early to have a shelter in place, and we did prevent having a surge, and yet we still have a lot of transmission, a lot of new cases every day. So I think what that tells you is that we haven't interrupted the transmission, okay? And so we talk about a basic reproduction number, which is how many cases will one person spread the virus to. And we think for COVID-19, it's in the order of 2 to 3 people. So if you don't have protection, one person is going to spread it to 2 to 3, you're going to spread to 4 to 9. Okay, so we're not seeing that in California, but we are still seeing spread. And so each person who's infected is still able to transmit it to, say, at least another person. Whereas to bring the number of cases down, you have to have that basic reproduction number below 1 so that someone who's infected doesn't pass it on to another person. So the bottom line is we have proof in California we haven't interrupted the spread. Now, where is the spread occurring? That we don't know for sure. But again, if you look around yourself, there are frontline workers who are being exposed. I feel sorry for the checkout clerks in the stores because they're being exposed to a lot of people. They aren't always 6 feet apart. So transmission may be occurring there to people who have to work and are exposed. I also think that we know that a lot of transmission, the greatest risk of transmission is in a household. So someone brings it into their home and their household members are going to get infected. We've seen some healthcare workers get infected as well. The bottom line is we still have transmission. What could we do to bring that transmission down? That's really tricky. We have seen other countries where they appear to have done that. Now, the question is either were they more effective, and this may relate to what precautions or measures were there to prevent spread. We have a lockdown, but it's really somewhat not enforced. It's up to you to do that. Okay, so maybe more draconian measures have been more effective in other countries. The other issue is we also don't know how reliable the reporting is. So are places testing? Are they reporting of the cases? So other countries which appear to have a nice decrease in their cases, that could be that they're doing a better job. It could be that they're not telling us the full story.
So yeah, it's a great question. And across the country, we've seen people challenged by this. And in part, you know, COVID has been treated as a political football, and we can't avoid that reality. So the backdrop of these questions where people urgently want to know how to do the right thing, how to protect themselves and how to protect their families. The reality is that the way in which much of this has been responded to from the very beginning has in fact been influenced politically. And that's problematic. With the dismantling of the Directorate for Global Health Security and Biodefense at the National Security Council, we lost time. Given that we knew that the first cases emerging worldwide were in November and December, had we in fact had that task force in place, it would have meant the deployment of the kinds of resources and the kinds of questions being put to Congress so that there could be the infrastructure building, so that there could be the request for appropriations as early as December or January. And this ties directly then to the questions with regard to access to PPEs. Had we been on the game of doing this earlier, we would have been able to have been further along. I think it's worth thinking about H1N1 in this particular context, because many people forget or don't know that H1N1 actually emerged here in the United States. But there was the turn to science, and there was the turn to health professionals and to public health experts and those who our pathologist and can track and trace and study these particular types of viruses, such that we were much further ahead. And one point that I'd like to add to that actually relates to the prior question about, masks and their availability, and it ties into another question that's come in, and that is the government can, in fact, do the types of things that can be responsive more effectively to generating more masks, to generating more PPEs. But we've seen struggles between states, and we've seen a struggle between the federal government. That's not ideal. These are not matters that should be dealt with, as a euphemistic political football, but rather these are, matters that should be dealt with in terms of health and science, and then utilizing what we know from health and science to then drive then how we respond and how we give resources appropriately. That's not what we're seeing nationwide. So while people have confusion in terms of why are some things opening in some places and other things not, that's not always related to what public health officials may be saying in certain states. Some of that is actually political response. And I think that that can be quite dangerous, because it can lead to the spread of this virus and can lead to people becoming sick, and sadly, in some instances, to people dying.
So thank you guys both for your answers there. Again, turning to a slightly more practical issue that I think some people tuning in from the community may be interested in understanding is knowing what we know about testing and the different types of tests that are out there, and how this is potentially going to help us think about reopening in a responsible way. Where can people get tests now? So we have several questions of how does that work on a granular level? Can you get a test at UCI without a referral? Are there pop-up clinics? What's emerging across the county or across the state that's really going to help people understand what options they have available to them? Ed, I'm directing that to you.
Yeah, so I can absolutely tackle that one. The obviously it's been changing quite rapidly. I can tell you a lot of us are taking the cues from CDC and those sorts of things in terms of the guidances there. And now they have expanded, and they have different priority groups in that they recommend getting tested. And some of those high priority groups currently are symptomatic people, particularly those in the hospitals or requiring hospitalization, first responders, healthcare workers, those living in very high-risk situations, for example, nursing homes. And then there's a second tier of priority, those that have symptoms that could be COVID, but may not be high risk. And then the ones that they're starting to give more flexibility to local healthcare agencies to allow testing would be asymptomatic people who may have had, for example, contact with high risks, or other reasons for public health agencies to want to get a sense for what the infection rate is in those people. So it is opening up in terms of the criteria for who can get tested. In terms of the practical matter, as long as you have a physician or a licensed medical provider, a physician assistant or nurse practitioner who's authorized to do that, who thinks that you need a test and they place an order or write it down in a prescription pad, then people can get the test. And there are different ways to do that. At UCI, for example, we have a couple of drive-throughs that you can make appointments to come through. There's tents to be able to get those tests, and other places have similar arrangements like that. If you don't have a physician necessarily, you can always call the triage line at UCI, and sometimes they can arrange for a licensed medical provider to screen that patient and say, yeah, you need a test, and you can get one, and we'll make an appointment for you. So there are different ways to do that. Typically, it currently does require an order from a licensed medical provider.
Okay, so thanks for that, Ed. I think because it's kind of related to this, a follow-up question I would ask, or a linked question that's come in, would be kind of two components, and I think the logical person to answer might be Daniela, but please Ed or Ming chime in as appropriate. So it's this: after the virus is gone, is the risk, the personal risk, gone? And in a linked question to that is, where does SARS-CoV-2 reside when there isn't an active outbreak? And so those two things kind of go together. I do think it's important to address this question about testing and symptoms and what risk is, especially given a little bit what we're hearing in the news right now about cytokine storm, especially in young kids, secondary consequences that may emerge really as a consequence of the virus and not necessarily be directly linked to the virus. And so I'm tossing that out to you guys. Raise your hand if you think you want to field that.
So I can get it started, though definitely I'm going to need help from Dr. Tan for part of the question. As I was discussing, the fact that the virus is out of the body doesn't mean that the body has healed. A lot of patients are going to have long-time disability and consequences. One of them, simple one, being pulmonary fibrosis after being on a ventilator. So when you think about what we need to do, it is very clear that we need not to only worry about the virus, but also worry about how we cure the patients that were affected by the virus. Kawasaki disease in children, it's another question. The strokes, because we are seeing a lot of hypercoagulable states, to the level that the FDA just recommended that we should give types of blood thinners to the infected patients. So there are a lot of questions that are still remaining to be discussed. The other question that remains very heavily on our mind, it is not clear, as Professor Tan said, for how long will the patients be immune once they clear the virus. And it's not even clear that every patient that was infected, it's immune even for a short period of time, because we know that different patients make different levels of antibodies. So where the virus reservoir is when people are not contaminated, I'll defer that to Dr. Tan.
Okay, thank you. So there is this interest in when a patient is infected, how long do they still shed, the term we use is shed virus, how long are they still releasing virus, and is that virus infectious for other people? And I think the important thing here to remember is that in terms of an infection point of view, it would be viable virus. In other words, virus that can go on to infect someone else. And the studies seem to suggest that for about a week, someone is shedding infectious virus, but maybe not so long after that. There may be some exceptions to that. Now, in a lot of studies, a lot of reports, what they'll say is they can still detect the virus, and what they mean is they can detect the viral RNA. So with the molecular test that Dr. Monuki was talking about. So that says that there's viral RNA there, but it doesn't mean that there's viable virus that can infect somebody. So what you hear is that, particularly in stool, in feces, a patient can actually have viral RNA detected for many weeks. It doesn't mean that that person is infectious. So one has to distinguish between them. I think the second question was about the reservoir for the infection. So this outbreak we're seeing is purely among humans. It originated as probably an animal, maybe a bat coronavirus, but we don't think animals are involved in the spread right now. You may have seen some highly publicized cases of tigers in the Bronx Zoo having symptoms. There are reports that cats can get symptoms. There are reports that dogs can be infected but not have symptoms, but there don't seem to be animals involved in the spread. So this is human to human. And so if we see cases go away from our community, it just means that there's no reservoir in our community, but right now there are, it hasn't been eliminated from the whole world. And so one scenario we could imagine is that in our community, cases go away, and then the question is, can it be reintroduced? And the answer is yes. And so I'm looking at places like China, places that had early outbreaks. Do they have new outbreaks coming in again? Because the people who haven't been infected are certainly vulnerable, and even people who might have been infected before, again, we don't know how much immunity they have. So the concern is that even after we play out this first round, can it be reintroduced into our community? And that's where testing and contact tracing is going to be important.
Great, thanks to both of you. I'm gonna do two more questions, if you'll all bear with me for a minute, just because I think they really are just particularly great. One to Michele, and then one that I'd like to have everybody sort of chime in on, because it's that kind of broad-reaching question. So Michele, the question to you, I'm kind of merging a couple together, is how does our legal infrastructure see the tension between the economic value of a society, between the, the economy and the moral status of individuals in that society? So in other words, how do we balance an economic cost? And are there precedents in this regard that we can look at from your perspective?
It's an excellent question. And let me say, part of this has come up within the last few days. Senator Rand Paul referenced Sweden and said, well, why can't we be more like Sweden? Sweden's taken a different approach. The children went to school. But therein lies some very interesting questions with regard to what are our nation's values. And that is, in Sweden, there's universal health care. In Sweden, there's parental leave, not just for women, but for men. Couples can, regardless of sex, have at least a year of leave. There's a social welfare infrastructure, and the society supports supporting people. That's not the same in the United States. We don't have universal health care. We struggle against, in the United States, a social welfare system. We cut back on food for children. We cut back for food for parents who are living at the poverty line. And so when we think about these infrastructural questions, then we have to think about, well, what are the values that we've had in our society? Now, it is true that we have had, in times of national crisis, when Roosevelt came into office, there was a dynamic uplift of social infrastructure. Many different programs came into being, a Social Security safety net, right? But we don't have many safety nets in our society. And so COVID exposes some serious questions for us. What will be our values going forward? How do we protect people, the most vulnerable in society? How do we think about where our values are, and how do we put our economic interest towards those values and lift all ships up? Now, in part, Congress has responded to that through the CARES Act, but clearly it's not enough. And, when one thinks about these kinds of questions, they're not just at the governmental level, but they're really at the individual level. How much do we care for our neighbors? And how much do we care for the neighbors that are some over? Right now, with people protesting at state capitals, it's very interesting to see the Confederate flag has made its way all the way up to Michigan. And there are people demanding that government reopen. And again, I've said that it's really important that we balance public health and safety with also the opening of society. But what's very interesting there is that we can think about how we frame these questions, right? Because we could frame questions such as, government, here's what people need in order to shelter in place through this. And let's respond to those needs. Or people can storm capitals with Confederate flags, right? And so we have to really think about what are the fundamental core values of our society. And that's not just top down from Washington, D.C., although we've seen how Washington, D.C. has responded, both in good and bad ways. But these also raise some very fundamental questions about how we care for each other in the society, and where we and how we will articulate our values going forward. If nothing else, what COVID has done is to expose certain infrastructural problems and certain institutional problems within our society. And for that reason, I think we see the kinds of disparities flowing out of this. And let me just add one more point to it, because it's a brilliant question, and we could just have a session just simply on that. And that is, how do we think about who happens to be essential during these times, and how we appropriately care for and provide safety nets for those people who are doing essential services? And here I'm talking not just about people who are in hospitals, so that's critically important, but there are a broader swath of people in our society who are doing essential services for us all. And it will say a lot about our values in the United States, how we regard and how we treat those people who are helping us.
That was fantastic, let me just say. Last question that I'm going to close on, I'm just going to read it out and then run through each of you in sequence because I really think it is a terrific question. It's a very thoughtful one. And it is, what would be the one policy that you would want to see altered or changed or implemented as society begins to reopen in order to protect the moral, the economic, the social status of the most vulnerable individuals that we have here in Orange County or in the United States more broadly? So Ming, I'm going to start with you.
Well, there's so many things we'd like. I think one of the things I'm looking at is we refer to contact tracing. In other words, when someone's infected, that you go out and you find who else is infected as a way of limiting the spread. And we are woefully prepared to do that. A lot of this has to be done, individuals going out and knocking on doors, and we don't have enough people to do that. Now, one of the issues has been, it's hard to do contact tracing when you have a lot of new cases. In Orange County, we have about 100 new cases a day. Each of those people, you'd have to find out who they had contact with. But again, if you're going to reopen up society, you're going to have to be able to trace the cases and prevent secondary spread. So I'd like to see better contact tracing. What that means is we need a better public health. So I think this whole crisis has exposed that public health matters for everybody. And we have not really invested in public health in the way that we should.
Thanks. Again, fantastic, very thoughtful answer. Ed, can we get your thoughts?
Yeah, I guess just to echo that, I think public health has been under-resourced, and that disproportionately affects the underserved communities, which is the focus of that question, as far as I understood it. So I do think that's huge. I guess if I could change one thing, it would be access in general. Again, we like to think about healthcare being equitable access across the board, but it just isn't because of lots of different practical and logistical issues. And I guess that would be the wish, is if we could somehow figure out how to provide equitable access to all the things that we were talking about.
Thanks again for a really thoughtful set of comments. Michele.
Well, I get to build off of my colleagues here because they've mentioned equitable access, doing the work for public health. So that would be a part of it, but I'll address the economic part of it, even though there's so much more, such as education. Boy, I'd love a quality, equal education for everybody in this country. But one of the things that we can do right away is that we can produce masks in this country. We can put people back to work doing that. We can produce PPEs and put people back to work doing that. We can produce tests and put people back to work doing that. So the economic questions here, we have infrastructure, and there are ways of seeing factories and other kinds of businesses that have gone away because of economic decisions that have been made over the last 2 or 3 decades. We can regenerate in those different spaces where people are hardest hit and actually do the work now to build out, not just for this pandemic, but beyond, and generate our economy.
Yeah, so that I have to say is a really interesting set of comments. I had a conversation with my daughter, who some of you saw Zoom bomb us during this event. I've just embarrassed her horribly now. But her question early on was, I don't understand. How can there not be enough masks? How can there not be enough stuff? And of course, it evolves to a much longer conversation about manufacturing and the economy of the United States and where it's based and how it became based this way. And so it's tough for us to look back at all the little decisions that led up as a deficit in terms of our infrastructure and being able to respond to something like this. As you pointed out, not entirely unanticipated, but something that we really need to look at and face, both in terms of supply for healthcare and in terms of supply for basic goods that are essential to be able to respond. Daniela.
I would go and I'll ask you to think about access in a different way. and I'll ask you to think about access to clinical trials. For people that live like me in the world of clinical trials, you know that majority of the medications that we use today were studied on white men. So if you are not a white man, if you are a man of a different ethnicity, or God forbid you are a woman, you don't know if what we do and what we develop will have the same effect on you as it has on a very homogeneous population. And when we work in university centers, we also realize that the patients that we treat with those new drugs, the ones that bring hope, are the people around us. And the people in the Indian reservation and the people in the underserved communities do not have access for different reasons, from distance, for education, from right communication, to the things that can save their lives. Or when those things become FDA approved, we don't know if it saves their lives as well as the lives of the people that we studied. So let's hope that we're going to be able in the future to generalize the access to what's new and exciting and life-saving to all the citizens of our country.
So on that note, I think it is almost 9 o'clock. We've been going about 2 hours. I would say I'd like to be respectful of everyone's time, but I clearly have not been at all. But I'll just let you know, you'll see in the side chat that's been relayed to you, we've gotten just some really wonderful comments from the community. I think people have been really glad to have your presentations and to have your thoughts. And there's been some really positive feedback. For the audience, again, I'd like to thank you all for joining us, and just restate something that I said earlier. If you had a question, and there are any number here that have not been answered tonight, we will circle back and post those online over the next day or two. This panel discussion has been recorded. It's going to be up on our website. It'll be available through these same streaming options. And so please, feel free to pass it on to people that you think might be interested. It will be available, and those questions will be up over the next couple of days. Thanks again for joining us. Many thanks to each of you as speakers. I think it takes an enormous amount of preparation to really distill all of the expertise that you have into content that can be reduced to a short, manageable bites. And I know that takes a lot of hard work. So thanks very much on behalf of the Center for all of your efforts, and good night.
Good night.
Thank you.
Thank you all.
Good night.
Stay safe.
And stay safe.